Great. Well, can you hear me? Because suddenly there is no voice at all. Good. If everybody can hear me, then I'll start with my presentation. Well, thanks again for having me here. My research covers the health insurance economics. Well, I understand this might not be very close to your research interest. So like during the presentation, if you find anything not clear or I should have explained it more clearly, please just unmute yourself and then I'm really happy to stop and then to make clarification here. Let me check, there is a chat note. Good. So the paper I'm going to present today is Determinants and Consequences of Poor Decisions in Health Insurance. This is a joint work with Christian Biener. He is a professor in behavioral economics from University of St. Gallen. So in the health insurance market, unlike the nations like UK, where the consumers are charged proportionally upon their income for health insurance, and they don't have to make any insurance choice regard to the coverage. The countries such as US, Switzerland, and other nations, the consumers are offered with generally a set of choice. These choice provisions aims at increasing the welfare by better matching individual heterogeneous preference and individual demand. However, there is a literature documenting ineffective decision-making. Those consumers make poor decisions, impair the policy motivation in the beginning. Inspired by this trade-off, our work asked two research questions. First, we ask, is a choice offered in the market optimal for individuals? And second, we would explore if their non-optimal choice in the market is a certain pattern for poor decisions. While there is a range of literature looking into the question, a stream of literature documented that different choice frictions might lead to non-optimal decision-making, such as the individual lack of financial literacy, inertia or inattention while making the decision, and also liquidity constraints. However, to tackle the trade-off I just brought up, this issue has been underexplored. The major challenge here is the lack of an empirical ideal market. As I have introduced, in some nations, individuals are mandatorily insured, leave consumers no choice, such as in Germany or in UK, or in US market, it is more complicated structure. As Liu and Signal in their forthcoming paper, they explored and find that the majority of the insurance product in US market are dominated by others. So here comes how our paper can contribute. We investigate an ideal empirical market to investigate the trade-off. So our paper contributes in two ways. First, we empirically test the vertical structure in health insurance, which is the one implemented in Switzerland. Second, we study instead of looking at what is the reason for consumers make poor decisions, we use a large comprehensive data to map the distribution of the choice quality to more specifically find the story behind who is making the poor decisions. So the presentation as following looks like this. I first would briefly walk you through the institutional background our paper relies on. In the second session, I would show the theoretical models, implementing the models to find the optimal contract under the system. Section 3, I would present the summary of the data we're using. And then like in section 4, I would mainly present the empirical analysis. At last, I would conclude and elucidate the policy takeaways here. So our work builds on Swiss health insurance market. It is an individual mandate setting without opt-out option, which means that each individual in Switzerland has to be insured individually, not by the family. And it is community rating, means that each individual are offered with an insurance package with the same price, irrespective of their age, their gender, their risk, and also their financial situation, like income. There are six options in the market. They only differ in deductible levels, the coverage level. This table here shows the financial attributes of the 6 plans, where you can see the deductible level increases from 300 default 1 to 500, and to the maximum 2,500 plan, a 10% of co-insurance applies to all the plan, and the co-insurance amount is capped at 700 Swiss francs for all the plans. In order to present it more visually, I mapped the consequence graph here. The x-axis here is the total annual incurred health cost, while the y-axis is the total cost borne by the insured. Here, let's take a look at this slash line as a 2,500. When the incurred health cost increases from 0 to tier 2,500, the cost would be completely borne by the insured. And then any amount exceeding the deductible level 2,500, a co-insurance of 10% would apply. The co-insurance amount of this stage would be capped at 700 Swiss francs. Then after this cap amount of co-insurance, extra incurred health cost would be completely covered by the insurance company. And the premium difference for contracts fixed at 69% of the extra deductible level. Most importantly, all covered services are identical across different plans and different insurers, which is an ideal setting because this leaves the consumer's choice only because of the coverage difference. We don't have to worry about the covered services difference would influence the decision making. So the next session, we implement several prevalent decision models to identify the optimal contract under the system. We start our analysis by implementing the expected utility theory, the constant relative risk aversion, while the risk aversion would decrease when wealth increases. The figure here shows the first ranking contract conditional on risk and risk aversion. By age and gender here, the age here represents the different health risk distribution generated by the federal office. As the age increases, the health would increase. And in our simulation, we enlarged the risk aversion role from 0 to 12 to get a more economic view of how rho means here. I put an example. When rho equates 5, it means the risk premium one would be willing to pay is 7,884 Swiss francs in order to cover the expected cost exposure of 2,800 Swiss francs. While among the previous literature, one of the most influential ones measuring the risk aversion parameter is Bayesian 2013's work, where they elicitate the reasonable range of risk aversion should be between 0.32 to 0.88. Following this literature, the key takeaway from this picture is that within the reasonable range of risk aversion, the optimal contract should always be either the gray one, the dark gray one, which is the 2,500, or the green one contract, which is the 300 deductible. We also do some sensitivity check using different level of initial wealth, or implement the constant absolute risk aversion, while we find the robust result, which is only the 2 boundary deductibles should be selected as the optimal contract under the EU theory. Next, we implement the rank-dependent theory and cumulative prospect theory. The rank-dependent theory here incorporates the probability weighting in the decision-making. Here, this figure shows the first ranking contract conditional on risk aversion, and probability weighting parameter. When the probability weighting parameter gamma increases to more close to 1, the probability weighting can be ignored. While the gamma decreases to close to 0, then individuals are more likely to overweight the small probability events. When gamma equals to 0.6, which is suggested by the previous literature, a more realistic situation, we find the similar result still within the reasonable range of risk aversion, even smaller than 2.5 here. Only the two corner deductibles are the contracts can be rationalized under the RDU model. Well, on the right-hand side figure, we plot the first ranking contract under the cumulative prospect theory. The cumulative prospect theory adds upon the rank-dependent theory by adding the reference point. Here, this figure presents the first ranking contract while using the reference point equals to the individual's expected health cost. Well, we see that within the reasonable range of risk aversion, the optimal contract still should be either 300 or 2,500. We also run some sensitivity check, implementing different reference points, such as using the 2,500 deductible out-of-pocket amount as a reference point. And here we can see the result still stands. So the key takeaway from this prevalent decision models implementation are listed here. First, we find that the risk appetite in our setting does not matter. They cannot explain the optimality of, they cannot explain why people select into the intermediate plans. Second, we find that in our setting, risk is crucial for choice optimality. We then relying on this fact, we decide whether a consumer is making a good or bad decision, crucially depending on their risk. So for the empirical analysis, we rely on the Swiss national survey data. It is a cross-sectional data, covers the myriad social demographic data, such as the household type, the educational level, the language they're speaking, their financial status, the company, the professional sectors they're working at. In addition, this data has concrete healthcare utilization data. However, this data does not have claimed cost. Therefore, we have to estimate the health cost. We implement the risk compensation scheme. Among the data, we classify individuals into different risk groups according to the cantons where they live, whether they have the specified 16-9 chronic disease, whether they spent overnight in hospital, and their age and gender, to estimate their health cost. Just to mark that this health cost we're talking about is different from the risk profile we implemented in the previous model session. In addition, this data also provides the health insurance choice data, which I will show you in the next slide. This table here shows a high-level summary. In total, we have 16,381 individuals with an average age of 52. 47% of the individuals are male. The average expected health cost is 4,465 Swiss francs. So next, this figure here shows an overview of the choice pattern based on the data set we're using. The choice patterns are listed conditional on the risk, as the x-axis here shows the probability of low cost. As x increases, people has lower risk, lower health risk. Therefore, people are more healthy. We see more people selecting into the 2,500 deductible plan. However, let's look at the right-hand side of this bar. Although all of those individuals in this group would be benefit if they select into the 2,500 deductible plan, still there are 55% of this group selecting into the non-economic ones. And in addition, we notice, irrespective of the cost here, we observe a certain proportion of individual select the intermediate plans, which are the non-optimal decisions here. Overall, we observe more than 40% of the population make poor decisions in our sample, which is consistent with what we observe in the Swiss population. Combined with the takeaways from the previous section, we define 3 types of poor decisions here. We define one is making a poor decision if one consumer picks one of the intermediate plans from 500 to 2,000. Or second, if a healthy consumer picks the highest coverage plan here, or if a sick consumer picks the lowest coverage plan here. So next, we look at who is making the poor decisions by running a probit regression. Because of the salience, because of the salience issue, we hypothesize that if one individual is expecting a high health cost, one would spend more time, more effort in making the decision, therefore end up in a higher probability of making better decisions. Therefore, before this, we explored the relationship between cost and the likelihood of they make optimal decisions. Here we find an inverse S shape. People who are healthier, they have the probability of making optimal decision around 37% compared to the unhealthiest individual who amounted 57% of the individuals making the better decisions. So one simple quick takeaway from this relationship is that we find healthy individuals in our sample are more likely to lose more for poor decisions, are more likely to select into non-optimal decision. So going back to the regression, the column 1 and column 2 shows the regression results investigated the impact of financial capabilities, which is proxied by the income here. And column 3 and 4 investigate the relationship of financial literacy, proxied by the level of education here. Forgive me, there is a mistake. There is a typo here. And column 5, we jointly include both the 2 elements, income and education, in the regression. What we find here is that both income and education are positively related to better decisions. When jointly regressed here, we find that income compared to education has a larger impact on choice quality, while controlling for health risk and other variables. In addition, we find in terms of the household composition, individuals who have children, they are less likely to make optimal decisions for themselves. And those who are self-employed are less likely to make better decisions for themselves. The key takeaway from this regression is that we find the less educated people, low-income individuals are more likely to make poor decisions than those who are not, which provides an indirect subsidy for those who are more educated and with higher income. Thus far, we have investigated how the observable observable characteristics would influence the choice optimality. Now we take a look at how the characteristics would change with different types of poor decisions. We look at two types, the overinsured and underinsured. By overinsured, we mean those who are healthy in our sample, but we select the 300 deductible plan. By underinsured, we refer to those who are unhealthy but select into the 2,500 plans. While the one plausible avenue to explain the difference falling into these two groups is a difference in risk preference. However, it is quite striking to notice that besides the smoking behavior is different, the gambling behavior has no significant difference across the two groups. In terms of the university, we find that people with a university degree are 2 times more likely be underinsured. And those people who work in the construction and mining are 1.7 times more likely to select into to be overinsured. And as well as self-employed people are more likely to be underinsured. We also observe an average loss from poor decision. We find that an average loss of 347 Swiss francs for the full sample against for those who are in the overinsured group, the average loss is amounted to 1,024 Swiss francs. And taking a look at those income group, the average income of people in the overinsured group is 103,000 Swiss francs, which is only 62% of the underinsured group. This gives us a hint that the healthy adults with modest financial conditions are more likely to be overinsured. To investigate the causal effect of low income on insurance optimality, we take a look at how the financial distress would impact the choice pattern. We use the propensity score matching method, find those individuals who has the exact same observable characteristics, but they only differ in the income level. Here, this figure plots the choice pattern condition on risk for 2 different income groups. While we see the left panel shows a consistent demand for the 300 insurance, 300 contract, irrespective of their risk. We explore there might be 2 possible reasons for the trend of overinsurance. One is the subsidy they receive. Second is those people who face the financial constraints might buy higher insurance coverage in order to seek for high risk protection. Our data stopped us from looking at exactly which reason, but my job market paper is investigating this question, and the preliminary result says that it is exactly both of the 2 reasons account for the low income people being overinsured in Switzerland. So to sum up what we have done in the paper, we find empirical evidence that there are dominated plans offered in the market, and there are more than 40% of the Swiss population select into the dominated plans. We document the evidence of inequality in choice quality. We find less sophisticated consumers make mistakes. Low-income individuals lose the most, resulting from poor decision making. In terms of the policy takeaways, the Swiss insurance market is implementing the textbook-like vertical structure in health insurance, while we find the empirical evidence suggested that vertical structure in health insurance has modest impact on sorting high versus low risk averse consumers. Instead, its primary redistribution effect is that sick consumers pay more, healthy consumers pay less relative to a single plan choice. We also find less sophisticated consumers make mistakes, which is an indirect subsidy to sophisticated, educated, high-income consumers. So here is the end of the presentation. This again, like I thank you for your attention. And this paper is still like close to the first draft of the work. It is still incomplete work. I just if you have any comments, it would be really appreciated. Thank you. So do you